Miss Dim Miss Dimano, anong purpose ng pulp?
Wait lang po. Ano po, the main purpose of pulp is it is the responsible formation po of dentin. It responds po to trauma and pulp forms secondary dentin at reparative dentin.
Aside from that, what is the most important role of the pulp? Miss Dimano,
Ano po, it provides po vitality to the tooth. It's following root canal work. That does not mean that the tooth is lost, and simply the tooth works without pain, but it loses the pulp protection.
what?
Ang functions po of dental health, it provides vitality of the tooth po. It allows following the root canal work that does not mean that the tooth is lost.
Say it in your own words, not from Google. It's the main function of the maintain the vitality of the pulp.
Ano po, medyo choppy po kayo.
In your own words, Miss Dimano, what's the main function of the pulp? Most important function of the pulp. Ikaw, Carl.
Ano po?
Nakapag-endo na ba kayo?
Opo, Dok.
O, so bakit hindi mo alam ang function of the pulp and nag-endo na kayo?
Ano po? Nutrition and formation of dentin po, Doc.
Aside from that, it was already mentioned. Aside from that, ano ang most important function of the pulp? Anyone who knows the answer?
Doc, Nico po.
Yes, Miss Kiko.
So besides from dentin formation po, the pulp also plays a nutritive role in supporting the dentin with moisture po and nutrients. And then it also has a defensive role of the pulp, which occurs to the development of new dentin. It provides a barrier between irritants and slow the rate of caries decay po.
In your own words,
Yun nga po, so it provides nutrients po.
the pulp is the one responsible for the nourishment of the tooth. That is why, after doing root canal treatment, the tooth is already dead. It's still there, embedded on the bone, but the tooth is already dead because there is no pulp anymore. So, ang pulp, it provides nourishment. Siya ang bahala sa nourishment of the tooth dahil siya yung may blood supply. Aside from the formation of the dentin because it contains forming cells sa dentin. Ang pinaka-importanting role ng pulp is the nourishment of the tooth. Ayun na nga, nasa slide ko na. The primary objective of the pulp therapy is to maintain the integrity and health of the teeth and their supporting tissues. Pulp is defined as a special organ with a unique environment of the unyielding dentin surrounding a resistant, resilient soft tissue of the mesenchymal origin reinforced with a ground substance. So this is the pulp cavity. For the deciduous tooth, you can see that the pulp is thinner. No, pulp cavity is larger kasi maliit yung ngipin. Manipis yung enamel, thinner ang enamel, thinner and dentin, so malaki yung pulp. With the permanent, the dentin is thick, pulp cavity is smaller. Why do you think on a permanent tooth, the pulp cavity is smaller? Why do you think sa permanent tooth, pulp cavity is smaller? These are the differences between the pulp cavity of a deciduous and the permanent. For a permanent, pulp cavity is smaller. Bakit? by just mere looking at the diagram, why do you think the pulp cavity is smaller with a permanent tooth? Anyone?
Makapal na po yung dentin, Dok.
Who's answering?
Karandang po.
Okay. Yeah, it's true. Because in a permanent tooth, the pulp cavity, the pulp tissue already performed its function, which is the formation of the dentin. So, the dentin is already bigger in size, so smaller na yung pulp cavity niya. Because nagawa niya na yung kanyang function of the formation of the dentin. So, when the pulp cavity is smaller, ang pulpal horns are also lower kasi makapal yung, these are the pulpal horns. Makapal na yung dentin, so mababa yung location niya. Unlike with decidus, it is so easy to perforate the pulp of a deciduous tooth because the enamel, because the tooth itself is small, so the enamel is thin, the dentin is thin, so you are very near to the pulpal horn already from the surface. So when you do cavity preparation on a deciduous tooth, you always have to be careful of exposing the pulp. Kasi nga, mataas yung higher ang location ng pulpal horn with the deciduous, lower with the permanent because of the thickness of the enamel and the dentin. Okay. Preoperative assessment is essential to determine whether pulp therapy or extraction is indicated. When you have a case of deep-seated carious lesion, masyadong malaki yung sira ng isang ipin, you need to do preoperative assessment. Do I have to extract this? Is this tooth indicated for extraction already, or I can still do root canal treatment to save? So it is essential to determine whether pulp therapy or extraction is indicated. We should consider the following: medical conditions, overall assessment of the mouth, space management and parental attitudes towards dental health, and assessment of the individual too. So when you do oral rehab, iba, pagbukas ng bibig ng pasyente, makikita mo kaagad ang daming cavities, ang daming carious tooth. So what do I have to do? Ano ang dapat ko bang gawin? Unang-una, ano bang dapat kong gawin? You have to know the medical condition of your patient, overall assessment of the mouth, kung kailangan bang meron akong kailangan space maintainer, if I extract this, o do I need to do a space maintainer, or hindi na lang kasi malapit nang mag-erupt yung succedaneous tooth. You have to assess the case first. This is pre-operative assessment before you do your treatment plan. Under medical conditions, every effort should be made to conserve the teeth in a hemophilia patient. Children with systemic conditions such as congenital and acquired heart disease, trauma or operative dentistry result in transient bacteremia from the gingiva. So pag merong mga heart problems, hindi siya pwedeng basta mo gagamutin. You have to do you have to give preoperative antibiotics or yung tinatawag nating prophylactic antibiotics. If your patient has medical conditions, it is a must that that the patient should acquire clearance first from their doctor before you do any treatment. Overall assessment of the mouth. For example, the dentist may invest more time and effort to save a pulpally involved second primary molar in a 4-year-old with unerupted first permanent molar and to save a pulpally involved first primary molar in an 8-year-old. Naintindihan niyo ba ito? Bakit mas gusto niyang i-save yung E? When you say E, that is the second molar. Bakit mas gusto niya pang i-save ang second molar ng 4-year-old than the first primary molar ng 8-year-old in this scenario? Why do you think? Kasi sa case ng 4-year-old, wala pa siyang first permanent molar. Kasi yung first permanent molar erupts at the age of 6. So, ang most posterior tooth niya, yung kanyang second primary molar. So, I will do my best to save it dahil walang magme-maintain ng bite because hindi pa tumutubo yung first permanent molar because the child is only 4 years old. With my 8-year-old, it's just fine to let go of the first primary molar because for an 8-year-old, malapit nang tumubo yung kanyang first bicuspid. So I'd rather save the second primary molar of a 4-year-old na unerupted ang first permanent molar than saving the first primary molar of an 8-year-old because the first bicuspid would already soon erupt. Oral hygiene should be modified. Management of space loss, the dentist must evaluate parents' attitude and improve it by motivation and education. Most of the time, ang mga parents, they do not want to restore the temporary teeth or the primary teeth because they always say, may tutubo pa naman, mapapalitan pa naman niya, sayang lang ang pera. They do not understand that the more should you save the primary teeth because yun ang guide ng mga permanent teeth sa pag-erupt nila. So, if you extract the primary teeth prematurely, malocclusion would happen. There is a big chance of having malocclusion because the teeth drift. Nagdi-drift ang mga ipin sa available space. So, but it's so difficult to convince the parents to have the teeth of their children restored because they always think na that's just a temporary dentition. There will be another teeth coming. Three considerations. Can the tooth be restored if the pulp therapy can be performed? Restorable pa ba ang ipin? When you are dealing with the primary teeth and you wanted to save the tooth, you can do pulp treatment on that. You can do root canal treatment, you can do pulpotomy. There are so many treatments, pulp treatment you can do in order to save the tooth. Ang tanong, is it worth it to save this? Na halos hindi naman na magiging restorable yung crown ng ipin because you cannot do dowel post and dowel post and core with a temporary tooth because mawawala rin yan eh. Kailangan nga when you do root canal treatment for a primary molar, kailangan resorbable yung pulp treatment medicament na ilalagay mo because kailangan mag-resorb ang roots ng mga primary teeth para maka-erupt yung permanent. Okay. Can the tooth be restored if the pulp therapy can be performed? Nothing was gained if pulp therapy is successful and the crown of the involved tooth is non-restorable or the periodontal structures are irreversibly diseased. So wala rin. Kahit i-root canal mo, hindi mo rin naman siya masisave. Stainless steel crown increase the chance of crown restoration after pulp therapy. Yan. You should not do any pulp treatment without the radiograph. Kasi with the radiograph, no, is it still worth saving? Is this tooth worth saving, ha, sa tingin nyo? Worth saving ba ito? Ito yung picture sa x-ray ng patient. Worth saving pa ba ito? Anyone from the class?
Hindi na po.
Why? Who is answering? Who is answering?
Pagkaliwanggan po.
Okay, Miss Pagkaliwanggan, why not?
Diba po, sirang-sira na rin po yung crown, tapos padating na rin po yung permanent teeth po. Teeth po.
Yeah, that's true.
Kitang-kita na rin
Pero
po pati
ang pinakamagandang sagot dito, but yeah, thank you Miss Pagkaliwanggan, your answer is correct. Meron lang tayong i-add up. This is not worth saving anymore. Why? Because you can see that the bone attachment of the roots, the bone support is compromised already. The permanent tooth that's soon to erupt, konti na lang yung bone on top of it. So meaning, this tooth, in this scenario, in this case of the panel of the radiograph, resort na yung bone under this primary second molar. Tama yung sinabi ni Miss Pagkaliwanggan, there is no more crown. So hindi ka naman pwedeng gumawa ng double post. So this is not worth saving anymore because the bone support of the tooth is already compromised because nasusudsud na siya, nare-resort na siya ng upcoming second bicuspid. So if you have a condition like this, it's nonsense to do root canal treatment or at least or restore. Sa bagay, pag ganito ng case, ito yung clinical niya, hindi naman na talaga siya ma-restore because there is no walls to hold on to the restoration. Thus, the dental age of the child need retention of that particular tooth. Dental age judged by root development when roots of the primary molars have been more than half resorbed by the eruption of the succedaneous, extraction should be made. So, going back, gawin nating example ang case na ito. If the roots is still quite long, but the bone support is not sufficient anymore. So in this case, it is best for this tooth to go. Extraction na. So radiograph, when you want to do root canal treatment or any pulp therapy, radiograph is a must. If the pulp status amenable to the pulp therapy, it will be answered in the diagnostic aid in the selection of teeth for vital pulp therapy. Kailangan natin ang radiograph because with regards to the decision or treatment planning, clinical assessment is not enough. We have to have a radiograph to see the bone support, to see the resorbed area, to see if there is abscess or periapical lesions. Let's go to diagnostic. Physical condition of the patient. You should know if the patient has congenital cardiac disease, immunosuppressed patients, children with nephritis, leukemia, tumor, cyclic neutropenia, uncontrolled diabetes. These patients, if your patients happen to have this ailment, they should not be treated without clearance, medical clearance, and without pre-operative medications. For congenital heart disease, it is a must that the patient has to take prophylactic antibiotics first before you perform any treatment, especially those treatments that would cause bleeding, to avoid bacteremia. History of pain. The history of either presence or absence of pain is not reliable in the differential diagnosis of the condition of the exposed primary pulp, as it is in permanent teeth. So, hindi pwedeng ang panuntunan mo lang, your only guide is, lagi po sumasakit ang ngipin ko, lalo na po sa gabi. So, that is just part of the diagnostics, pero hindi po pwedeng yun lang yung maging basis mo. But you ask the patient, may pain ba to? Kailan sumakit? Gaano katindi ang sakit? How do you measure the degree of the pain? In scale 1 to 10, asan po ang pain doon? Nasa 7 po. Nasa 8 po. So, also for you to have the idea kung anong klaseng pain. Less than a minute, join na lang tayo again. To continue, provoke pain. Stimulated by heat, cold, sweets, air, and chewing. When the stimulus is removed, the pain is reduced or disappears. These signs often indicate that the pulp is vital. So when there is pain, stimulated by heat, cold, sabi na, pag uminom po ako ng tubig, masakit because mangilo. Pag kumakain ako ng stick-o, after pag stick-o, masakit ang ipin ko. Pag tumatawa ako, nahanginan yung na-expose ang ngipin ko sa hangin, masakit. If you can still feel those kind of pain, it means that the tooth is still vital. Spontaneous pain usually wakes a child at night and may not relieve by analgesics. These signs usually indicate advanced irreversible pulp damage. So pagka yung nagigising ka na dahil masakit ang ngipin mo, in an advanced stage na ang problem ng pulp. Clinical examination, abnormal tooth mobility, tenderness to percussion, may swelling, size of exposure, and amount of pulpal bleeding. So these are the things that you have to see or check when you do clinical examination. And next is radiographic interpretation. When you found out na umuuga na yung ipin, the tooth is already mobile, what is the indication of that? Anyone? When there is tooth mobility, what is the indication of that? Anyone from the class? Anyone? Ano ibig sabihin kapag umuuga ang ngipin? What happens? Ano nangyayari pag umuuga ang ngipin? Lorna?
Ano po, indication po na may possibility po na tutubo na po yung succedaneous teeth.
Before tumubo yung succedaneous teeth, we are not talking about eruption here. We're talking about pulp therapy. Is this tooth indicated for pulp therapy or not? How will you save? What's wrong with the tooth? We're on the diagnosis. So, what is happening when the tooth is mobile? Ano nangyayari? Bakit siya mobile? Angelica?
Either po, Dok, yung bone po niya ay resorb na po or pwede rin po may periodontal disease po siya.
Bakit hindi naka-turn on ang video mo, Angelica?
Dok, ako po yung nag-chat po sa inyo na nasa biyahe po, Dok. Sirat.
So, anong indication kapag may mobility?
Ano po, pag po kita po sa pag po may mobility po, yung po ginagawa pong assessment po sa tooth mobility po, na tinutulak po ng
Bakit nga? Ano ngang indication kapag may tooth mobility na itulak-tulak mo na and there is mobility? Anong ibig sabihin nun?
May periodontitis po either ang patient po. Or,
Bata pa, may
po,
periodontitis na.
bata po. Or either po mag-exfoliate na po ang
What is happening kapag may bone mobility? Anong nangyari? Bakit siya naging mobile?
nabawasan po yung either po na nagkaroon po ng resorption po.
So may bone resorption, nabawasan yung bone support. That is why the tooth is mobile. That is what also happens when the patient has periodontitis. Kasi pag may periodontitis, nagkakaroon ng bone resorption. So umuuga din ng ipin. So when the periodontitis is on the moderate to severe, there is tooth mobility. Pero sa pediatric, nagmo-move ang ipin because meron ng bone loss. May resorption of the bone, so meron ng kulang na yung bone support. That is why the tooth gets to be mobile. Maraming causes. It can be periodontal in nature or nagkaroon ng bone resorption because the succedaneous tooth will erupt soon. Different types of pulp therapy. For the deciduous teeth, we have indirect pulp capping, direct pulp capping, pulpotomy, and pulpectomy. For young permanent teeth, we have indirect pulp capping, direct pulp capping, pulpotomy, apexogenesis, and apexification. We have treatment for vital cases, and we also have treatment for non-vital cases. When you say vital pulp therapy, ang ibig sabihin nun, the tooth is still vital. Buhay pa yung ngipin. May sensation pa, may pain pa, so nangingilo pa. So it is an indication because it still has feelings, di ba? So, buhay pa yung organism. So for vital pulp therapy, we can do pulp capping. Why do we do pulp capping? What is the purpose of pulp capping? To maintain pulp vitality by placing a suitable dressing either directly on the exposed pulp or a thin residual layer of slightly soft dentine remains. So, ang pulp capping, we have two types of pulp capping. We have the direct pulp capping or indirect pulp capping. Ang direct pulp capping is like this one. Exposed na yung pulp. Normally, ang na-expose yung pulpal horn. So, yung mga spikes, yung mga horns ng pulp, yun ang parating na accidentally na-expose. So, when there is exposure, no matter how big or small it is, kahit pinpoint lang yan, there is pulp exposure. When we put medicament, that is what we call direct or direct pulp capping. In cases like this one, malapit nang ma-expose pero hindi pa naman talaga siya exposed. Meron pang thin residual layer of slightly soft dentine. Pag naglagay ka ng medicament dyan, pulp medicament, you are doing indirect pulp capping. So for this one, you have to do direct pulp capping. For this one, indirect pulp capping lang. So ang difference lang nun, when you say direct pulp capping, there is exposure. When you say indirect pulp capping, may natitira pang very, very thin layer of dentine. Hindi pa talaga nearly exposed but not exposed yet. Indirect pulp capping is used when the tooth has a deep carious lesion. It may be successful in the primary dentition provided that the seal of the restoration is intact. So, kailangan lang yung restoration nyo ay intact when you do an indirect pulp cupping. History, indication of the pulp cupping. For history, kailangan may absence of spontaneous pain. Sumasakit lang kapag natitrigger but not spontaneous pain. Ibig sabihin, tuloy-tuloy. Clinical examination reveals large carious lesion in close proximity to pulp. Absence of lymphoadenopathy and the color of the tooth is still normal. Kasi pag patay na class ang ipin, nag-grayish na siya because there is no more nourishment because the pulp is already dead. When the pulp is dead or there is no pulp, then the tooth is also dead. So radiographs, you have to look if the case on the ligament space and lamina dura, and there is no interradicular or periapical radiolucency. Because kapag may periapical radiolucency na, it means that the tooth already has abscess. It is not a good case for pulp therapy. Okay, contraindication for pulp cupping, prolonged spontaneous pain and nocturnal toothache. So walang sakit paggabi, walang tuloy-tuloy na pagsakit, pwede pa siyang i-pulp cupping. Pero kapag merong tuloy-tuloy na pagsakit, pulp cupping will not be enough. Sharp pain that persists after removing the stimulus. Pag uminom ng malamig, pero pagka tinanggal niya na yung malamig na tubig sa bibig, nawawala yung pain. So, indicated pa siya for pulp cupping. Clinically, merong excessive tooth mobility, tooth discoloration, non-responsiveness to pulp testing technique, contraindication yan. Wait lang ha. I will just make it clear here. When you already have the radiographs, you have to look at the periodontal ligament space. Kailangan wala siyang interruption, wala siyang maluwang na space, kasi kapag may maluwang na space, that is an indication of bone loss already. And there should be no interradicular or periapical radiolucency because that's an indication of abscess. Okay, for the contraindication. If there is prolonged spontaneous pain and night pains, hindi siya pwedeng i-pulp cupping. Clinically, pag merong tooth mobility, hindi rin siya pwedeng i-pulp cupping na. Tooth discoloration, hindi rin. Because when the tooth is already discolored, na grayish, then the pulp is already necrotic. It's an indication that the tooth is already dead. Non-responsiveness to pulp testing technique. Naglagay ka na ng malamig, mainit, matamis, walang pakiramdam yung ipin. So, it means the tooth is already non-vital. So you will also try to look at this when you have the radiograph. Large carious lesion with apparent pulp exposure, interrupted or broken lamina dura, widened periodontal ligament space, radiolucency at the root apices or interradicular area. That's a contraindication. Kasi parang yung kanina, it's just a clinical, what you see. Pero ito, yung nakikita mo naman sa x-ray. If you have all this sa x-ray, sa radiograph, then the tooth is not indicated for pulp cupping. So, upon removing the carious lesion, you accidentally expose the pulp, you have to do pulp cupping. So, you remove the caries, you clean the area. This is how you do the pulp cupping. You place calcium hydroxide. So, ang technique na ginamit sa kanyang pulp cupping is calcium hydroxide. Then you place zinc phosphate or glass ionomer. We don't use the zinc phosphate anymore. We use glass ionomer. So, muntik mo na, nearly exposed, pulp, you do pulp capping. Best filling material for pulp cap glass ionomer. If you accidentally expose a pulp when you are doing your restoration and you accidentally expose the pulp, nagkaroon ng pinpoint bleeding, naku, na-perforate yung pulp. What do you have to do? Direct pulp capping ang gagawin mo kapag ka na-perforate mo yung pulpal horn. So, paano ba gawin ang direct pulp capping? On the picture, say for example, you accidentally exposed, you will dry the cavity. Wait, ba't pa tayo nandito? Ito, caries removal muna. Magka-caries removal ka, and then, if it's near to expose the pulp, you will put calcium hydroxide and other medicaments, and that is indirect. If indirect pulp capping. So you remove the caries, you clean the area. Kunyari wala tayong exposure. Deep-seated lang yung cavity. What's happening to my slide? Wait a while. And after cleaning the area, you put calcium hydroxide. And then, after calcium hydroxide, you put zinc phosphate cement or glass ionomer. So, we don't use zinc phosphate anymore. But there are places na gumagamit pa rin sila ng zinc phosphate. But best is glass ionomer. Okay, so direct pulp capping is the procedure of covering the exposed vital pulp by a material which promotes healing of the vital tissue. Pulp capping is not recommended if the diameter of the exposure is greater than a pinpoint. So pagka sobrang laki ng pulp exposure, hindi na po pwedeng direct pulp capping lang. If it's just a pinpoint, then you can do direct pulp capping. It should be limited to traumatic exposure in cavity preparation. Ang tawag natin dyan mechanical exposure. Na-expose mo kasi you are draining out. Small pinpoint exposure surrounded by sound dentine. Mechanical or carious exposures in asymptomatic vital young permanent teeth. Recent exposure and vital pulp free from infection. So these are the indications that you can still do pulp capping. No bleeding at the exposure site, and normal radiographic findings. Walang periapical lesions, walang widening of the lamina dura, walang tooth mobility. May sensation ng ngipin that is indicated for pulp treatment, for pulp capping. Contraindications: cariously exposed deciduous teeth. The diameter of the exposure is greater than the pinpoint. There is a history of spontaneous pain. There is more than gentle bleeding from the exposure site. Pathologic mobility, pus or exudate from the exposure site, and also fistula. Yan, contraindicated na siya for pulp treatment. Okay, technique, isolate the tooth. When you say isolate, you use a rubber dam or Or if you don't have rubber dam, you should put cotton rolls up the side of the tooth, on the buccal side and on the labial side. Buccal or labial and lingual or palatal. Isolate the tooth, prepare the cavity in a normal way. You remove all the carious lesion. Gently with excavator, you clean the area. All the surfaces that can be cleaned by using excavator, you just excavator. You only drill when it's necessary, and you clean the area. First, removing peripheral caries, then proceeding towards the pulp sa floor. Non-irritating solutions such as normal saline or chloramine should be used for irrigation of the exposure site before placement of the capping material. Calcium hydroxide is the material of choice of capping exposed vital pulp tissue. When placed, the material should not be forced into the exposure site. ZOE is placed over the calcium hydroxide layer as sealant, then zinc phosphate cement. The permanent restoration is inserted at the same appointment. But this came from an old literature, so we don't use zinc phosphate, glass ionomer. Direct pulp capping is generally contraindicated for primary teeth because pulpal inflammation usually persists, increased cellular content, and the result in total pulp necrosis or internal resorption. This by transforming of cells into odontoclast and stimulation of osteoclast. Rapid spread of inflammation throughout the primary coronal pulp due to increased blood supply. I would lecture on I would give that another lecture for MTA. It is also used for pulp capping, but in the past it is always calcium hydroxide that we use for pulp capping. But nowadays, meron pang isa na pwedeng gamitin for pulp capping, and that is MTA. Now, that MTA thing, pwede siya sa primary teeth gamitin. But for calcium hydroxide, contraindicated siya for primary teeth for direct pulp capping kasi according to research, calcium hydroxide causes resorption ng tooth structure. So medyo may konting conflict regarding that. Pero when I lecture the MTA, maintindihan nyo. So for now, still calcium hydroxide is the best material to use for pulp cutting or pulpotomy. I will continue my lecture for pulpotomy and pulpectomy next time. Balik lang tayo sa pulp capping ha. I-clear ko lang. With pulp capping, we have two kinds. We have the indirect and direct. Magiging direct pulp capping siya kung merong pulp exposure. Indirect pulp capping kung walang exposure but merely to expose the pulp already. So, yung mga deep-seated cavity preparations. And what do we do? How do we manage? How do we do the pulp capping? You put a layer of calcium hydroxide, and then if it's really deep, you can put ZOE on top, and then you use glass ionomer. Or pwede na calcium hydroxide lang, thick calcium hydroxide, and then glass ionomer. And then you leave it for a month. And then after a month with no symptoms, you remove half of the GI and then you put the permanent restoration, which is composite. Pagka kailangan i-build up yung crown, then you do build-ups. But after not month, a week lang, ang pulpotomy ang 1 month. So, sometimes when you do pulp capping, direct pulp capping, merong pulp exposure, pinpoint lang. With my technique, I don't put permanent filling at once. what I do is, I put calcium hydroxide, put glass ionomer, and then I wait for 1 week. 1 week muna. Just to check on the, what will the status be of the tooth. Pagka sumakit siya, it means the tooth is rejecting the pulp material already. So, I do not do, whenever the case is very deep, pulp capping talaga, may accidental exposure or may exposure, pinpoint exposure of the pulp, hindi talaga ako permanent filling at once. I observe the tooth muna for 1 week and I just put calcium hydroxide and glass ionomer. But for my indirect pulp capping, indirect meaning walang pulp exposure, we can do direct composite restoration at once. So you put the calcium hydroxide, you put the GI, and then you put the composite. Now, class, there is no chemical bonding between ZOE and composite. So, hindi mo pwedeng, you should not use composite on top of the ZOE. Hindi siya nag-adhere to each other. Just to explain to you, I don't know if I told you this story already. I attended a seminar. It's an endo seminar. And the teacher, the lecturer, wrote on nakasulat dun sa slides niya. You cannot use composite resin restoration on top of the ZOE. Tama naman yon. Pero ang explanation niya kasi is nagbavari yung aking signal. Ang explanation ng lecturer, kaya daw hindi pwedeng gamitin ang composite of the ZOE is because kinakain daw ng ZOE ang composite. Medyo wala yata akong librong napagbasahan na kinakain ng ZOE ang composite because on her lecture, she showed a slide wherein nasira yung composite niya. She has this case, deep-seated cavity prep, deep-seated cavity. Nilagyan niya ng calcium hydroxide, nilagyan niya ng ZOE, then nilagyan niya ng composite. Bumalik si patient kasi after few months na basag yung kanyang composite. And ang explanation niya kaya hindi ka daw dapat maglagay ng composite on top of the ZOE is because kinakain ng ZOE ang composite. Mali yun. Hindi kinakain ng ZOE ang composite. Kaya siya nabasag because there is no chemical bonding between ZOE and composite. They are two different materials. Kaya siya nabasag. Imagine, may ZOE. After ZOE, you put composite. When you do light curing, when you light cure the composite, expose it to light, what happens? Bakit tumitigas? Ang composite, pag nila-light cure, anong tawag dun sa process na yon? Tandaan nyo pa ba yon? O hindi nyo talaga alam? Taas ang kamay ng hindi alam. Huwag mahiya para maturuan. What happens kapag ka nila-light cure mo? Nag-light cure ka sa composite, tumigas si composite, di naman sinisidus. O anong nangyari doon? What happened to that? Anong process ang nangyayari? Bakit tumitigas yung composite? Ba't siya nagsiset pagka nila-light cure? What do we call the process? Yung nangyayari. Taas ang kamay ng hindi alam. Sige na, taas ang kamay para alam ko kung hindi nyo alam o alam nyo. Taas ang kamay. Pag hindi kayo nagtaas ang kamay, lahat kayo sasagot. Okay. Taas ang kamay nang hindi alam ang sagot. Huwag mahiya. Nasa screen kayo. Hindi ko kayo mapapagkulit. Masisira ang laptop ko. Okay. Dami hindi alam. Sige, taas lang. Yan. Siguro, absent kayo nung i-lecture yan ni Dr. Kenneth. Ano? What happens? Polymerization. Ang tawag dun sa process, kung bakit tumitigas yung composite pag nilalike mo is polymerization. Nagpo-polymerize. Diba yung mga monomers, nagdidikit-dikit sila. Yung mga fillers, nagdidikit-dikit sila. Pag inilawan mo, magdidikit-dikit sila para sila tumigas, para mag-set, diba? So, pag nagdikit-dikit sila, halimbawa, magtapon ka ng yung mga marbles. Kasi yung mga monomers, para yung mga marbles. Yung Jolen. Jolen nga ba ang tawag doon? Jolen nga yun, yung mga marbles. Pagka nagsama-sama, di ba? Pag scattered yung Jolen in a bowl, lagay mo yung Jolen. O sa floor. Pag pinagsama-sama mo yung Jolen, what happens? Parang nag-shrink siya. Di ba? Naiwan yung space, nag-shrink siya. So, pag nag-light cure ka, polymerization, shrinkage happens. Dahil dikit-dikit na yung mga monomers So, kaya may polymerization, shrinkage kapag nagla-light cure ka. So, kung ang pinatungan mo ng composite ay ZOE, wala silang chemical bonding because they don't have any chemical wala silang parehong chemical content. So, pag nagkaroon ng polymerization shrinkage, what happens? Nagkakaroon ng gap. Nagkakaroon ng space between ZOE and the composite. So, pag si pasyente kumagat sa mga tigas, kinagat ang buto ng chicken, o matigas ang kinagat niya, mababasag yun. So, kaya nababasag kasi may space, nabubuslot, nababasag, nababreak kasi nagkaroon ng space between dahil nga wala silang hindi siya nagbaband sa ZOE pero hindi naman kinakain ng ZOE yung composite. Hindi lang sila nag-band together so meron siyang gap, magkaroon ng space so pag kumagat si patient ang matigas, magko-collapse ang kanyang restoration. So hindi nyo pwedeng gawin bakit pag glass ionomer pwede? Nag-a-adhere ang glass ionomer sa composite, pero ang ZOE hindi. So, yun yung reason. What happens pag nilalagay cure, nagkakaroon ng polymerization. At pag nagkaroon ng polymerization, nagdidikit-dikit yung kanilang components, nagkakaroon ng polymerization shrinkage. Kaya meron na tayo ngayon na calcium hydroxide na light curable. Meron siyang photo-initiator, kaya siya nagsiset pag nila-light cure. So, ang composite at ang calcium hydroxide na light curable, meron silang bonding because they both have photo-initiator, yung sensitive sa light, para mag-set. More to learn. But anyway, yon. So, mag-stop muna tayo sa direct pulp cupping ha. Again, direct pulp cupping, may pulp exposure. Indirect pulp cupping, wala. Pero nearly, malapit nang ma-expose. On both problem, you put calcium hydroxide. So, how do you stop the bleeding? Nag-expose ka ng pulp, nagbi-bleed siya. So, hindi dikit yung calcium hydroxide kasi basa yung surface. So, you have to control the bleeding first. How do you control the bleeding? Pulp, ano ba tawag dito? Cotton pellet, ilagay mo lang dun sa socket, dun sa cavity, parang may pressure, or yung cotton pellet mo, i-wet mo siya ng anesthetic solution. Then, ilagay mo dun. Mag-stop ang bleeding. Bakit? Kasi ang anesthetic solution natin ay merong epinephrine. So, nagko-constrict ang blood vessels. So, nag-i-stop siya. Ma-bleed. So, it's either by pressure using cotton pellet or mag-wet ka ng cotton pellet sa anesthetic solution and then lagay mo doon for a minute and then tanggalin mo but do not blow air from air syringe kundi ang ipandadry mo ng cavity ay cotton pellet pa rin. Then you put your calcium hydroxide. When it sets, you put your glass ionomer. And then, kung ito'y direct pulp cutting nga, if sa assessment mo, pwede kang mag-direct composite restoration after glass ionomer, pwede namang you do it at the same time, same day. Pero kung gusto mo munang mag-observe, uwi lang ang patient ng naka-glass ionomer, filled lang ng glass ionomer. Pag walang symptoms, no negative reaction, in a week, then the patient will go back, you remove half of your glass ionomer and fill it up with your final restoration, which is composite. Now, with the indirect pulp cupping, you can already put your final restoration kasi wala naman siyang pulp exposure. Nag-anticipate ka lang na magkaroon ng problem, so you put calcium hydroxide. Now, class, when you are dealing with a vital tooth, deep-seated cavity preparations with nearly exposed pulp, you don't use acid etch. Ang gagamitin mong adhesive, if you're going to restore it with composite, ay yung non-etch adhesive. Kasi your etchant is an acid. So, since newly cut ang inyong cavity, newly cut ang dentin, open ang dentinal tubules. So, pag hindi ka naging maingat with your acid etch, pag nagpunta siya sa dentin area, maa-absorb siya ng dentinal tubules, pupunta siya sa pulp. After a month, madadaing ang patient ko na masakit ang kanyang ngipin. Pag tinignan mo, may pasta naman, wala namang leak, but masakit. It's because nag-cause ka ng pulp problem because of the etchant. Nagkaroon ng irritation and na-inflame yung pulp because of, nagkaroon ng pulpitis because of your etchant. So, when you are dealing with cavity that is very deep, especially when there is a pinpoint pulp exposure, wag kayong mag-e-etchant nang hindi kayo nakakapaglagay ng medicament first. Pwede ka nang mag-etchant kapag may glass ionomer ka na. Kung hindi ka pa rin masyadong sosyalin at ang iyong process ng pagpapasta ay gumagamit ka pa rin ng etchant, you be careful na hindi po pwedeng mag-go directly ang etchant sa dentin na hubad, meaning walang protection. Ang protection ay calcium hydroxide or glass ionomer. Wag kang gagamit ng acid etch kasi ang acid etch, ang etchant ay acid, so it will irritate the pulp.